And I'm very pleased to call on stage Professor Carranza from Buenos Aires. Nelson Carranza is one of the leading experts in plastic aesthetic surgery, and he will report on his technique.
Easy. Thank you. Well, good afternoon, everybody. I'm Nelson Carranza. I have no conflict of interests. And I will be talking this afternoon about the laterally stretched flap, or LAS flaps, a technique that I feel is very suited for the lower anterior recessions. So this is, I guess, the green one. No, where's the green button? No stress here. Well, throughout this presentation, I will present you what the last concept is about and the technical variants. I will focus mostly on one of the variants, which is the last envelope technique, that I feel is very as an efficient and simple technique. And by the end, I will touch a bit on a more complex situation, and I'll show you how we deal with more complex, or how LAS flaps can deal with more complex situations. These are publications a few years ago where we described the techniques. And last Europerio in Amsterdam, we presented the results of our first 21 cases, where we could see that we were having very good results as far as root coverage, and pretty much comparable to many other successful techniques applied to the lower anterior areas. And we were also obtaining very good results as far as keratinized tissue. Now we are working on a second paper with 60 cases for over more than now 6 or 7 years. And the results are pretty much the same. So we're quite confident that this is a very predictable and effective technique. I don't like to think about the last technique as a, cookbook recipe technique. But I'd like to think about it as an advanced management of flap that is combined, or when combined, with other more traditional techniques. And so far, we have 3 mainstream variants: the last tunnel technique, the last envelope technique, and a combination of a laterally stretching and coronal advancing of the flap that we call the last cuff technique. The first one, the last tunnel, is very much similar to what Dr. Skullion just showed. Actually, now, at least that I know of, there are 3 different independent groups that came up with pretty much the same technique. And I don't think that's a coincidence, because there's sure somebody there that's thinking that I've been doing this closing of tunnels for many, many years. And I believe you, so were we. In fact, I think for more than 20 years, when we saw, after the tunnel, we saw that graft bulging out through the recession, we just go ahead and try to close it. Sometimes we closed it completely, sometimes we didn't. And the difference between what we are doing now and what we were doing then is that nowadays, beforehand, we're planning the surgery so we can close that tunnel. And that implies that there are certain technical characteristics that we have to take into account that make the closure of that recession very predictable and also safer. So the laterally closed tunnel, or the last tunnel flap, which is essentially a very, very similar technique, is a wonderful technique. It can give you amazing results, like in this case. But, and it does come with a but, nowadays, I don't do so many tunnels. There are some drawbacks associated with the last tunnel. First of all, I feel more comfortable when I see what I'm doing, especially since I use magnification aids. I like to see what I do. I take more advantage of my instruments. So I have to go in with blind dissection. I cannot discern whether I'm doing full thickness, partial thickness. I cannot tell if I'm trying to do partial thickness, how thick the tissue I'm leaving against the bone is. So I also run into high risk of perforation, especially in the lower anterior, where the bone anatomy is sometimes very uneven with deep concavities. Graft insertion is another issue with the tunnel. If we make the tunnel correctly, then the graft fits snugly into the tunnel, and we take advantage of one of the main advantages of the tunnel, which is wound stability. But now, if we make that graft fit snugly into that tunnel, we cannot stretch those tissues. So we make our tunnels, as Dr. Skullian said, very ample, especially downwards. And now we run into two new problems. First of all, we lose some of that wound stability, which was one of the main advantages of the tunnel. And the other thing is that we also saw in Dr. Skullian's video, the graft tends to slip downwards. So we end up looking for the graft down there, picking up with an explorer, trying to suture it in place. And that adds a lot of time and sometimes even a lot of stress. But don't get me wrong, I believe tunnels are wonderful if they can be achieved correctly. However, I believe now that we have a better technique, at least a simpler one, and as effective as the tunnel. And it's called the last envelope flap with connective tissue grafts. The last envelope is based on the envelope technique described by Bruno, a technique that we mostly used and researched for RT2s and RT3 recessions. But soon after we started working with the last tunnel approach, we decided to try it with the last envelope in RT2s and RT3 recessions. And it worked wonderfully. But we also noticed something else, that our surgeries were way much easier. Things were faster. The closing of the tunnel was easier. Inserting the graft and placing the graft in the position we wanted was easier. But mostly, now I had control of how precisely I could elevate the flap. And you can see it here in the photograph in the middle. This is one of the first cases, though. Oh, this is from 215, and this is the result a few months ago, 7 years after the fact. And you can see how precisely I can choose where I elevate full thickness, where I elevate partial thickness, how deep and how neatly I can go against the very uneven bony architecture. So I will concentrate on this case. This is a young lady. She has a deep, narrow recession in one central incisor, but if you look closely, you'll see that there's a very thin phenotype on the other central. So the objective is to close that or cover that recession and thicken the phenotype on the other central. I will show you through the video how we reach to this point where we prepare the flap, we close the recession, we harvest a graft that is very even in shape and is exactly 1 millimeter in thickness to end up with this situation. So this is the surgery. We begin with horizontal incisions, and that incision has to be placed about 1 millimeter above the place where we want to place the graft. It can be more, but it cannot be less than that. You want to make that incision about 1.5 to 2 millimeters in depth. Usually at this point, at this level of the papilla, you will hit the bone. So you might go against the bone anyway. But after that, we want to raise the flap. And for raising the flap, I use this instrument. This used to be a tunneling instrument before I grabbed this sharpening stone and placed a sharp edge on it. So this is a tunneling knife, and I usually elevate my whole flap with this modified instrument. I keep on sharpening it throughout the surgery, but very neatly and very precisely and mostly very safely, because I run very little perforations with this. I go sideways, sometimes, most of the times, with a concave part against the bone, and very safely copy that very uneven surface of the bone with my instrument. I want to elevate a little bit more in full thickness. I just changed the side of the instrument. I use it as a periosteal elevator. So I go back and forth, moving that instrument all along, choosing and actually measuring how much tissue I leave attached to the bone. And usually I tend to leave a little bit of very thin tissue in the more coronal part of the flap. And as I move downwards, past the mucogingival junction, I tend to leave a more thick amount of tissue, and I'll show you in a few minutes why that's the case. But I keep on going, detaching the most coronal aspect of those muscle attachments, which is the first part of the flap elevation. That's a periosteal elevation that I will complement with another elevation, which is called, what I call the submucosal elevation, and most of you know as the superficial elevation. So I go into that submucosal space between the submucosa and the muscles, first with a sharp blade, getting space, or getting an entry into that space. And soon after that, I will grab again my tunneling knives, and sort of in a semi-blunt dissection, I will go and open that space. And that gives me more control and less bleeding than going ahead with the sharp blade. But you can do it anyway. The thing is that you can achieve here 2 levels of flap elevation. One very close to the periosteum, one over the muscles and down between the muscle and the submucosa. So you can achieve a very mobile, hypermobile flap in the way Giovanni Zucchelli taught us many, many years ago. Now, with a very mobile and elastic flap, I can start closing the recession. Nowadays, I always start from the apex and move coronally. I use double cross sutures. My first suture is placed at the base of the recession. I'm using a 7.0 suture. You can use, as Dr. Skulin said, as a 6.0 also, but I wouldn't use anything thicker than that, making sure my entry points in the tissue is not too close to the gingival margin, at least 2 millimeters. And move forward. So in this case, I will place 1 suture, and then I'll go again a little bit towards the coronal aspect, and in and out with another cross. Some people ask me whether I should take the epithelium out of that recession, and my answer is no. I've never taken it, but my priority is the integrity of those tissues. I don't want to risk having that tissue become more fragile by removing the epithelium, which actually gives some strength and integrity to it. So I do not remove the epithelium. I haven't been doing that for the last 10 years, and I don't think the results we have justify attempting to do so. So this is the closure, and you can notice the finger of the assistant. This is a critical part when we reach the end of the suturing, because we don't want the retractor of the assistant pulling very hardly on the lip and transmitting that tension over those tissues. These sutures are very, very fragile. After that, or before that, suturing, we treat the root surfaces quite gently with an ultrasonic with a diamond coated. Now, I will harvest the graft with a technique that we published in 2020. It's called the modified double blade harvesting technique. And it's a modification of the single harvesting technique described by Hurtzeller and Wang back in 1999. So we begin with an incision about 2.5 millimeters away from the gingival margin. We detach a little bit of that tissue, just slightly, that we can see that you see that connective tissue, and you can see where the lamina propria ends and the submucosa begins. We want the double blade, which has 1 millimeter apart, the blades, gets the lamina propria. So we get close to the epithelium, and look at the speed of the video. This is 4 times, so I go slowly. I want control of where my blade is. And you see the blade by translucency. Very slowly, always having control, moving a little bit, advancing, moving a little bit. There's no second chance to do this incision right. So you have to get it right from the first time. Then I'll go over again the edges with a tunneling knife, just to make sure the things are well cut. And after that, we will cut the perimeter, the edges. I go mesially first, then I will go apically, trying to keep my blade horizontally, and this incision defines how tall my graft is going to be. And usually for these techniques, 5 millimeters is enough. And then I go with the distal incision. So I remove the graft, and this is the graft almost as it came out from the mouth. Just a bit of tiny tissues has been taken out. And you can see this very even, and it's about 1 millimeter in width. This is the technique I use to suture the palate, especially when I don't want knots on the facial side when I'm using some sling sutures. If the palate is not bleeding, this is an excellent way to suture the graft. It has also been described in the article in 2020. So we put the graft on the table with saline solution. I place a little bit of prep gel for 1 minute, rinse thoroughly, apply some Emdogain. We routinely apply Emdogain to all our recessions. We place the graft, and in this case, where the teeth are very evenly distributed, there is no discrepancy, apical coronal discrepancy of the tissues. There are no very deep bone concavities. Then you can go with the simplest way of doing this, is suturing the graft and the flap with the same suture. You will see in other cases that when this is not the case, I will suture the graft first to the bed, and then I will suture the flap on top of the graft, but not in this case. But you can notice that that suture is not in the middle of the papilla, it's just a little bit measly. And that is because I will do the sling suture in a double fashion. So I go a little bit mesial on the papilla, I go through the graft, through the papilla, to the lingual, come out on the facial, distal papilla, also puncture the papilla mesially, come back, and now I'm puncturing that papilla distally. And I'll repeat the same thing on the other papilla. Go through the flap, the graft, the papilla towards the lingual. And there's always some orthodontic retention there to make things a little bit difficult. And you see I'm suturing, I like to suture my flap with my fingers. I tend to accommodate the flap a little bit with my finger at the end. So I don't use microsurgical instruments by themselves in the last suturing of these type of flaps, most of the times. Then I'll go with the other suture, and this is going to be this is the typical sling suture that we use for coronally advanced flaps. The only exception is that I will go intensely through the flap, through the graft, through the papilla. I will take the distal papilla, which has not been elevated as an anchor papilla, just to make sure everything is stable. And this is pretty much the whole suturing of the flap. So this is a surgery that is being done much faster and simpler and easier than the tunnel. And I have to tell you, most of the times now when we have these type of recessions, we use the envelope approach rather than the tunnel. And this is the result 1 month after the surgery. You can see the flap healing very nicely. The palate is healing almost completely by now. This is 3 months, and this is 18 months, 1.5 years after we've done the surgery. Excellent root coverage, very good aesthetics. And also on the other tooth that we wanted to, this is the before and after, where we wanted to thicken the gingiva, you can see that we also achieved that goal as well. So the indications for the last envelope and also for the last tunnel is single, deep and narrow. This is the cases where these surgeries thrive. And when I mean deep, I mean at least 4 millimeters, 4, 5, 6 millimeters, 10 millimeters, doesn't matter how far it goes. The technique really, really works. There are some variations you can use for other cases. Another good thing about the thing I like at this technique is you can use it as a site-specific and just have a small graft for 1 tooth or 2 teeth, or maybe just use a larger graft, maybe and do more like an area specific approach. So let's talk about one complex case, and I've taken all the way to the extreme to the most complex case I can imagine, which is recessions, deep recessions all along. And for that we have the last calf, the combination of both tissues. And we're going to be taking advantage of the stretchability of the tissues that we find below the mucogingival junction. So below this line, everything moves very easily. Above this line, things do not move very easily. So our flap design will take advantage of that. At the bottom of the recession, we will stretch laterally, not one recession, but all of them. And from the mucogingival upwards, where things do not move very easily, we're going to be moving that coronally. This is the design. We're working on the publication on this design as well. And notice something about the incisions. The incision on the deepest recession is divergent to that recession, not convergent. It's divergent. So here's the flap elevated. We are moving on a periosteal level with that tunneling instrument, working myself with the concave part of that instrument against the bone. And as I go further down, I want a thicker layer of tissue. I mean about a millimeter, not more than that. And I will go down as far as the muscle tells me to do so. In this case, since we're moving coronally, we need to deepithelialize those papilla. So this is the bed after the papilla have been deepithelialized, and then we go ahead in the same way as we did it before with the submucosal flap detachment. With a knife at the beginning and then with the other instrument. And we can see now we achieved sufficient stretchability of that tissue, so we can now close the recessions. Not one recession, but 4 of them, with some caveat. Now, we do not need to close all the recession up, just half of it, which means it's easier. Only the most stretchable part. You can see there how we achieved it. We go to the palate, we harvest the graft, again with a 1 millimeter blade. We prepare the roots as you've seen before with Prep Gel and Emdogain. And as soon as we place the Emdogain, we go ahead and place the graft. We want a thin layer of Emdogain. We don't want lots of the Emdogain on top. And now here's where I say thank you for leaving that tissue down there, because that enables me to do this sort of Holbrook suture from the coronal to the apical. I do that in several different ways, always with resorbable sutures, of course. And then on top of that, I will suture the graft. So we will end up with this result. And this is the before, how we planned it, and this is how it looks like. This is a closed vision of, you can appreciate the apical part of that recession over the roots. And this is as far as I went with this case. This is only 6 weeks ago. This is how the patient looked last week before coming here. I think at this point we're completely out in the clear as far as the results. I'm sure this is evolving very, very nicely. And you can see the before and the after with a very decent position of the mucogingival junction, enhancement of the phenotype, and probably very, very good prognosis. So, to conclude, the last envelope has many advantages. First one, and most importantly, is visibility and access. I like to see what I do. I like to see how much tissue I leave attached to the bone, if I would do it partial, full thickness. But also, especially in the lower anterior, I can deal with high muscle attachments. So many times I will detach periosteally, maybe 5-6 millimeters beyond the mucogingival junction, but if I have a high muscle, I might go 1 centimeter, 1.5 centimeter, no problem. I even went that as far as doing some myectomy of that muscle. I can also remove the frenum from the inside in the same way Dr. Skullion just talked about. And that is done, you can do it with a tunnel, but if you see it, it's easier. The fact that we are detaching the papillae makes the flap a little bit more stretchable than with the tunnel approach. And that makes closing the recession easier. And again, as I talked before, you can use the site-specific approach or an area-specific approach. It's just a matter of how big your flap is and how big your graft is. So here we see how we are closing the recession. This is a different case. This is a more like an area-specific approach where we're going to be treating 3 teeth instead of just 1 or 2. And since we were talking about grafts, the tendency nowadays is to go for smaller grafts. And it's obvious why. Because smaller grafts have less morbidity, less pain for the patient after the surgery, and mostly less risk of bleeding. So our grafts are thin, they are about 1 millimeter in thickness. They are taken or harvested close to the epithelium so we can ensure that there's a part of it, mostly is lamina propria, part of it is the more dense lamina propria, but the other part is a little bit the less dense lamina propria, which is more vascular. And also they are only about 5 millimeters in height. And we can achieve, or we can make our grafts smaller because we're covering our grafts with our flaps. The other thing is about the axis allows us to position our grafts in the place we want it very, very precisely, and also stabilize them with stability sutures, making the adaptation of the graft against the bed very close, very intimate, ensuring good nutrition and ensuring us that we will not suffer graft necrosis. So this is the final suturing, and you can see how we suture this case. We have a technique that is fast, at least faster than the tunnel in my hands. It will provide and can provide very good aesthetic results and is highly predictable. So this is the end of my lecture, and I want to take the chance on behalf of my group and myself, first of all, to thank the organizing committee for this amazing opportunity. It was the dream of my life to present here at Europerio. But most of all, I want to thank you. You've been an amazing audience, staying there all the time. Thank you very much.